So welcome friends. So here we are to resolve the question of what made our patient orthopnic. So before starting, I would like to make it clear that this video is going to be a bit longer compared to the other videos because there are 5 major options in our question which needs a bit detailed explanation. So be with us till the end. You'll definitely take away 5 concepts with you today and you'll never regret this later. So yeah, let's begin with the question first. A 50-year-old man has been a smoker for 25 years. He has worsening orthopnea over the past 6 to 7 months. On examination, he has a BMI of 34. He is afebrile. His blood pressure is 155 by 110 mmHg. Auscultation of his chest reveals rales in the lower lung fields bilaterally. A chest X-ray shows bilateral lower lobe infiltrates and a prominent left heart border. Lab studies show his HbA1c is 9.5%. Which of the following pulmonary conditions is he most likely to have? So yeah, starting with pneumonia. So directly said, pneumonia, if we assume it to be an infective type of pneumonia, and infective type of pneumonia needs to have at least some signs of infection. If not, if the patient actually doesn't present with what you call breathlessness, he should have cough and fever to call it pneumonia. Yeah, there are atypical types of pneumonia where the patient directly walks into the OPD. The patient is so fine, and so we also call it as walking pneumonia. But what in general we talk about is lobar pneumonia, and it needs to have the typical signs of infection including fever, cough, and excessive sputum production and all. So yeah, and also X-ray finding of prominent left heart border is not in much support of pneumonia, so we can rule out pneumonia effectively. So now we come to fibrosis. So yeah, fibrosis is the second option. So what exactly is happening in fibrosis is that it follows a restrictive pattern of lung disease. So what is happening is the lung is not able to expand because the fibrotic tissue is pulling the lung inside. So it is not able to accommodate that much of air, and also the fibrosis throughout the lung is actually impairing the gaseous exchange. So what happens is over a period of time the patient will go into chronic hypoxia, and what we know is what happens to the blood vessels in case of hypoxia. All the blood vessels in the body go in a state of vasodilation in case of hypoxia, but pulmonary vasculature undergoes vasoconstriction. So yeah, so pulmonary vasoconstriction has now taken place. So due to this there will be pulmonary artery hypertension, and due to this there will be right ventricular hypertrophy, which over a period of time, if not cured, would go into right ventricular failure, and hence all the symptoms of right ventricular failure like edema, ascites, and hepatomegaly and increased JVP. So yeah, this doesn't seem to be that case here. So this way we can rule out that this is not fibrosis. Now we come to the third option, which is atelectasis. So what is atelectasis is basically it's a term used for absorptive type of lung collapse. So what is absorptive type of lung collapse is, so either there is a obstruction in the bronchus. So this can be either due to excessive mucus, excessive exudates, or a neoplasm, or there can be something externally compressing the bronchus. So this can occur due to enlarged lymph nodes, or again due to some other neoplasm, and also due to an aneurysm which is compressing on the bronchus. So yeah, this is what is atelectasis or absorptive collapse of the lung. And also you would not find any infiltrates, and you would find a picture of lung collapse on the X-ray, so which is not the case here. So it's not atelectasis. So we'll leave pulmonary edema at one side now, and we'll see about emphysema. So yeah, let's see what exactly happens in emphysema. So what emphysema is all about? Emphysema is all about destruction of the alveoli and the bronchioles. So basically the airways undergo destruction, and we are classifying it as a COPD. So where exactly is the obstruction then? So what normally happens in a physiological condition is during the phase of expiration, the bronchioles compress. The diameter of the bronchioles decreases. So what in COPD what happens is there is excessive compression, which we call as dynamic compression of the airways. So what happens is due to this small diameter, the air is not able to move out of the lungs. So there is trapping of air inside the lungs, and hence you would find hyper resonant lung in cases of emphysema. So again in this question we have that the patient has bilateral infiltrates. So in emphysema we would not find infiltrates just like that until and unless there is a superadded infection along with emphysema. In that case, yes, we could find bilateral infiltrates. So I think we can also rule out emphysema this way. So yeah, now we're left with only pulmonary edema. So just let's mark it as the correct answer and let's go away. I'm joking. So now, yeah, let's see why is it pulmonary edema, and why are we suspecting pulmonary edema here. So what is happening is, the patient has all the possible risk factors for ischemic heart disease. So he's a smoker since 25 years, and his HbA1c is 9.5. His BP is 155 by 110. His BMI is 34. So the patient is a high risk patient for ischemic heart disease, and connecting orthopnea with all these risk factors along with BP. I'll tell you why this BP is important, because connecting all this, we can be sure that the patient is in heart failure. So to be more specific, the patient has a left ventricular dysfunction. So at this point, we are not very sure whether this is a systolic dysfunction or a diastolic dysfunction, because there are some factors like blood pressure, which is more in support of diastolic type of an heart failure, and ischemic heart disease is more in support of systolic type of heart failure. So at this point, we are not very clear about this, but something which we are very clear about is that the left ventricle is not functioning properly. So the blood has now started to accumulate in the pulmonary veins, causing pulmonary venous hypertension. This pressure is transferred back to the capillaries, pulmonary capillaries. So there is hydrostatic pressure is increased in the pulmonary capillaries. So now the fluid starts to leak out of the pulmonary capillaries. So this fluid starts accumulating in the interstitium, and with time it starts to accumulate in the alveoli. At this point, we call that the patient has pulmonary edema. So on an X-ray, what the picture is given here, it exactly looks the same whatever is given here. So initially the fluid accumulates in the lower parts of the lung due to gravity, and that's what is given in the question. The patient has bilateral lower lobe infiltrates and bilateral lower lobe rails on auscultation. So yeah, we can be very sure that the patient is in a state of pulmonary edema now at this point, and but we are again not sure whether this is a systolic type of heart failure or a diastolic type of heart failure, or it can be also both types together. There's one more point given in the X-ray description, is that there is a prominent left heart border. So on an X-ray, if you see what forms majority of the left heart border on an X-ray is the left ventricle. So there's a possibility here that there's enlargement of the left ventricle, which is making the left heart border prominent. So why would there be enlargement of left ventricle in this case? So if the heart failure is due to hypertension, which is a diastolic type of heart failure, the heart has to pump against the increased afterload in cases of hypertension, and the patient has a BP of 155 by 110 mmHg. So the left ventricle would undergo hypertrophy, which would cause left ventricular enlargement and hence prominent left heart border. And if it is due to ischemia, so ischemia could lead to ischemic dilated cardiomyopathy, again causing cardiomegaly, again causing left ventricular enlargement, and again causing prominent left heart border. So yeah, we've figured out every condition is satisfying pulmonary edema. So yeah, the correct answer to this question is pulmonary edema, and we have also seen why it is not something else. So yeah, we've taken away 5 concepts with us today. Let's stay updated with the upcoming cases. So you all can just let me know in the comment section what next system you need me to cover in this. So we have left with endocrine, we've left with infectious diseases, and if any other system which is left, we can surely cover up the questions regarding that. So yeah, stay tuned. Please like, subscribe, share this channel as much as possible so that it can benefit all of us, and stay tuned, stay happy. All the best. Thank you.